Welcome to this continuing education course on domestic violence for Florida healthcare professionals. This course is designed to fulfill the requirements established under Florida statutes, Section 456.031, which mandates that healthcare providers licensed in Florida complete education on domestic violence to maintain their professional licensure. The reason this requirement exists is straightforward but critically important. Healthcare settings provide a unique and often irreplaceable opportunity to identify victims of domestic violence who may never disclose their abuse in any other context. As healthcare professionals, you encounter domestic violence survivors at higher rates than almost any other profession. Your patients present with injuries, chronic health conditions, mental health concerns, and reproductive health issues that may be directly or indirectly related to abuse occurring in their intimate relationships or households. Throughout this course, we will explore the comprehensive landscape of domestic violence, from its foundational definitions and prevalence data to the complex dynamics that characterize abusive relationships. We will examine the profound health consequences that domestic violence inflicts on survivors, learn evidence-based approaches to screening and assessment, understand the legal framework governing documentation and reporting in Florida, and develop practical skills for intervention, safety planning, and referral to appropriate resources. We will also address the unique needs of special populations and apply our learning through detailed case studies. By the end of this course, you will be able to identify the prevalence, patterns, and types of domestic violence affecting patients in Florida healthcare settings, including physical, psychological, sexual, economic, and technological abuse. You will recognize the dynamics of domestic violence, including the cycle of violence, power and control tactics, risk factors, and barriers that prevent victims from leaving abusive relationships. You will be able to select appropriate evidence-based screening tools and apply assessment techniques to identify patients experiencing domestic violence in a trauma-informed, culturally sensitive manner. Additionally, you will identify proper documentation techniques for domestic violence cases that meet Florida legal standards, support patient safety, and preserve evidence for potential legal proceedings. You will distinguish between mandatory and permissive reporting requirements under Florida law and identify the appropriate procedures for reporting domestic violence as specified in Florida statutes. You will select appropriate treatment interventions, safety planning strategies, and referral resources to connect victims with Florida's certified domestic violence centers and community services. Finally, you will recognize the effects of domestic violence on victims, children, and families, including physical health consequences, mental health impacts, and considerations for special populations including elderly, pregnant, LGBTQ+, and culturally diverse individuals. Let us begin by establishing the foundation for understanding domestic violence through an examination of definitions, types of abuse, and the epidemiological data that reveal the true scope of this public health crisis. Module 1. Foundations of Domestic Violence. Under Florida statutes, Section 741.28 domestic violence is defined as any assault, aggravated assault, battery, aggravated battery, sexual assault, sexual battery, stalking, aggravated stalking, kidnapping, false imprisonment, or any criminal offense resulting in physical injury or death of one family or household member by another family or household member. The law specifies that family or household members include spouses, former spouses, persons related by blood or marriage, persons who are presently residing together as if a family, or who have resided together in the past as if a family, and persons who are parents of a child in common regardless of whether they have been married. The broader public health definition encompasses intimate partner violence, which refers to physical violence, sexual violence, stalking, and psychological aggression by a current or former intimate partner. This definition recognizes that domestic violence extends beyond physical assault to include multiple forms of abuse that may occur simultaneously or in patterns over time. As healthcare professionals, you must understand both the legal and clinical definitions to effectively identify and respond to domestic violence in your practice. Physical violence includes any intentional use of physical force with the potential for causing death, disability, injury, or harm. This encompasses hitting, slapping, punching, kicking, burning, choking, or strangulation, use of weapons, and any other act that causes physical harm. Physical violence often escalates in frequency and severity over time, and healthcare providers frequently encounter patients presenting with injuries at various stages of healing. Sexual violence encompasses any sexual act committed or attempted against a person without that person's freely given consent, including forced or coerced sexual contact and unwanted sexual experiences. Reproductive coercion, such as sabotaging birth control or pressuring pregnancy decisions, represents a distinct form of intimate partner abuse. Sexual violence within intimate relationships is often underreported due to shame, fear, or the misconception that forced sex within a relationship does not constitute assault. Psychological and emotional abuse involves behaviors that harm a victim's self-worth or emotional well-being. Common tactics include constant criticism, humiliation, threats, intimidation, isolation from family and friends, and manipulation. While psychological abuse may not leave visible marks, research demonstrates that it can be equally or more damaging than physical violence in terms of long-term mental health outcomes. Economic abuse involves controlling a victim's ability to acquire, use, and maintain financial resources. Abusers may prevent victims from working, control all household finances, withhold money, damage credit, or create debt in the victim's name. Economic abuse creates significant barriers to leaving abusive relationships, as victims may lack the financial means to establish independent housing or support themselves and their children. Technological abuse has emerged as an increasingly prevalent form of domestic violence in the digital age. This includes monitoring victims through GPS tracking, spyware on phones and computers, controlling social media accounts, online harassment, and using technology to stalk or threaten victims. Healthcare providers should be aware that abusers may have access to victims' devices and communications, which has implications for safety planning and confidential conversations. Now let us examine the prevalence data that reveals the true scope of this public health crisis. The Centers for Disease Control and Prevention's National Intimate Partner and Sexual Violence Survey provides the most comprehensive data on domestic violence prevalence in the United States. According to this survey data, approximately 41% of women and 26% of men experience contact sexual violence, physical violence, or stalking by an intimate partner during their lifetime. Nearly 1 in 4 women, or about 24%, and approximately 1 in 7 men, about 14%, have experienced severe physical violence by an intimate partner. The World Health Organization estimates that globally, about 1 in 3 women, or 30%, have experienced physical and/or sexual violence by an intimate partner or non-partner sexual violence in their lifetime. A systematic review and meta-analysis of 201 studies encompassing over 250,000 women has confirmed these prevalence estimates, while also documenting the profound mental health consequences, including significantly elevated odds of depression, post-traumatic stress disorder, and suicidality among intimate partner violence survivors. 12-month prevalence data reveal that domestic violence is an ongoing crisis affecting millions of Americans each year. Survey data indicate that approximately 5.5 million women and 5.2 million men experience contact sexual violence, physical violence, or stalking by an intimate partner annually. These numbers likely underestimate true prevalence due to underreporting, stigma, and barriers to disclosure. Florida experiences significant rates of domestic violence that mirror or exceed national trends. According to the Florida Department of Children and Families Domestic Violence Annual Report for fiscal year 2023 through 2024, domestic violence affects hundreds of thousands of Florida residents annually. The Florida Partnership to End Domestic Violence reports that Florida's 42 certified domestic violence centers provided services to 398,829 individuals through direct service referrals and responded to 75,746 crisis hotline calls during fiscal year 2023 through 2024. These statistics represent only individuals who sought services through the formal domestic violence service system. Research consistently demonstrates that the majority of domestic violence victims never report their abuse to law enforcement or seek formal services, meaning the actual number of Floridians affected by domestic violence is substantially higher than documented service utilization suggests. The economic impact of domestic violence in Florida is substantial, with victims experiencing lost wages, medical expenses, legal costs, and decreased productivity. Communities bear costs related to law enforcement, court proceedings, emergency shelter, and healthcare. While domestic violence affects individuals across all demographic groups regardless of age, gender, race, ethnicity, socioeconomic status, education level, or geographic location, research has identified certain factors associated with elevated risk. Individual risk factors include young age, history of childhood abuse or witnessing violence in the home, substance use, and pregnancy. Relationship factors include relationship conflict, jealousy, and controlling behaviors by partners. Certain populations experience disproportionately high rates of domestic violence. Survey data document elevated rates among American Indian and Alaska Native women, women with disabilities, and individuals identifying as bisexual. Immigrant populations may face unique vulnerabilities related to documentation status, language barriers, and social isolation. LGBTQ+ individuals experience intimate partner violence at rates equal to or higher than heterosexual cisgender individuals, with transgender persons facing particularly elevated risk. Understanding population-level risk factors helps healthcare providers maintain appropriate clinical suspicion, while recognizing that any patient, regardless of demographic characteristics, may be experiencing domestic violence. Universal screening approaches, which we will discuss in detail later in this course, help ensure that providers do not rely solely on risk factor assessment while potentially missing victims who do not fit expected profiles. Healthcare settings represent one of the most important venues for domestic violence identification and intervention. Research indicates that domestic violence victims utilize healthcare services at significantly higher rates than non-abused individuals, often presenting with injuries, chronic pain conditions, mental health concerns, or reproductive health issues. For many victims, healthcare providers may be the only professionals they encounter outside their abusive relationship. Studies examining healthcare utilization patterns demonstrate that intimate partner violence survivors have increased rates of emergency department visits, hospitalizations, outpatient visits, and prescription medication use. Many victims present multiple times before their abuse is identified, representing missed opportunities for intervention. Healthcare providers who understand the presentation and dynamics of domestic violence are better positioned to recognize these patterns and offer appropriate support. The healthcare encounter provides a unique opportunity for confidential conversation and assessment. Unlike other settings where victims may be accompanied by their abuser, healthcare protocols typically include private time with patients for sensitive discussions. Providers who are trained to recognize warning signs and create safe opportunities for disclosure can serve as critical links to safety and resources for domestic violence survivors. Multiple healthcare specialties encounter domestic violence victims in their practice. Emergency medicine providers see acute injuries and crisis presentations. Primary care providers may identify patterns over time through ongoing relationships with patients. Obstetric and gynecological providers screen during pregnancy and address reproductive health concerns. Mental health providers treat depression, anxiety, PTSD, and other consequences of abuse. Dental professionals may identify oral facial injuries. Pediatric providers encounter children affected by violence in their homes. Each specialty requires appropriate training and protocols for addressing domestic violence within their scope of practice. Before we move on, let me address terminology and language considerations. Healthcare providers should be familiar with the various terms used to describe domestic violence and their implications. While domestic violence remains the most commonly used term in legal and service contexts, public health literature increasingly uses intimate partner violence to describe violence between current or former intimate partners, regardless of cohabitation status. Family violence encompasses violence between any family or household members, including child abuse and elder abuse. The term victim is used throughout this course to describe individuals who experience domestic violence, consistent with legal terminology and Florida statutes. However, providers should recognize that some individuals prefer the term survivor as it emphasizes strength and agency rather than victimization. In clinical encounters, providers should use language that respects individual patient preferences while acknowledging the serious nature of their experiences. Language choices in documentation and clinical communication matter significantly. Providers should avoid language that blames victims, minimizes abuse, or suggests that victims are responsible for their own victimization. Phrases such as patient claims or alleged abuse may undermine victim credibility, while documentation that objectively describes injuries and patient reports provides appropriate clinical and legal support. Module 2: Dynamics of Domestic Violence. Now that we have established the foundational understanding of what domestic violence is and how prevalent it is, let us examine the complex dynamics that characterize abusive relationships. Effective identification and response to domestic violence requires understanding these dynamics. Healthcare providers who understand these patterns are better equipped to respond with empathy rather than judgment, recognize why victims may remain in or return to abusive relationships, and provide support that meets victims where they are in their journey toward safety. Domestic violence is fundamentally about power and control. While specific abusive behaviors may vary, the underlying dynamic involves one partner establishing and maintaining power and control over another through various tactics including physical violence, emotional manipulation, isolation, economic control, and coercion. Understanding this framework helps providers recognize abuse that may not involve physical violence and appreciate the comprehensive nature of victims' experiences. The cycle of violence, first described by Lenore Walker, identifies a pattern that characterizes many abusive relationships. This cycle typically consists of 3 phases that repeat over time, often with increasing severity. Understanding this cycle helps healthcare providers recognize the context in which patients present and anticipate their needs at different phases. The first phase is the tension-building phase, characterized by increasing stress, poor communication, and minor incidents of abuse. During this phase, victims often describe walking on eggshells, attempting to keep the abuser calm and prevent escalation. The victim may minimize problems, make excuses for the abuser's behavior, or blame themselves for the tension. Healthcare providers may encounter patients during this phase presenting with stress-related complaints, anxiety, or seeking to establish care just in case something happens. The second phase is the acute battering incident, which represents the discharge of tensions built during the first phase. This phase involves the actual abusive episode, which may include physical assault, sexual violence, severe psychological abuse, or a combination of these. The acute phase is typically the shortest but most dangerous phase of the cycle. Healthcare providers are most likely to identify abuse when patients present during or immediately after this phase with injuries or acute distress. The third phase is the honeymoon or reconciliation phase, which follows the acute incident and is characterized by the abuser's expressions of remorse, apologies, promises to change, and loving behavior. During this phase, the abuser may seek to minimize what occurred, blame substances or stress, or promise the abuse will never happen again. Victims during this phase may minimize their injuries, decline referrals to services, or defend their partner. Healthcare providers should understand this dynamic and maintain a supportive, non-judgmental approach, regardless of the victim's current stance toward the relationship. The Power and Control Wheel, developed by the Domestic Abuse Intervention Project, illustrates the comprehensive tactics abusers use to establish and maintain dominance over their partners. Physical and sexual violence represent the outer rim of the wheel, with various controlling behaviors at the center. These tactics work together to create an environment of fear and control that makes leaving extremely difficult. Isolation involves cutting victims off from family, friends, and support systems. Abusers may monitor communications, control who victims can see, spread rumors to damage relationships, or move frequently to prevent victims from establishing community connections. Isolation makes victims increasingly dependent on the abuser and reduces opportunities to seek help or develop safety plans. Emotional abuse encompasses constant criticism, humiliation, name-calling, and manipulation designed to destroy the victim's self-esteem and sense of reality. Gaslighting, a form of psychological manipulation where the abuser causes the victim to question their own perceptions and memory, is particularly damaging. Victims subjected to prolonged emotional abuse may doubt their own judgment, feel responsible for the abuse, or believe they deserve mistreatment. Using children as a tool of control is common in abusive relationships. Abusers may threaten to take children away, use visitation to harass, undermine the victim's parenting, or use children to relay messages or spy. Fear of losing custody or concerns about children's safety may significantly influence victims' decisions about leaving. Economic abuse creates financial dependence that makes leaving extremely difficult. Tactics include preventing the victim from working or sabotaging employment, controlling all money, providing an inadequate allowance, damaging credit, or creating debt. Victims without financial resources may be unable to afford housing, transportation, childcare, or legal representation necessary to establish independence. Coercion and threats maintain control through fear. Abusers may threaten to hurt or kill the victim, children, other family members, or pets. Threats of suicide are common manipulation tactics. Abusers may threaten to report victims to Child Protective Services, immigration authorities, or employers. These threats create a climate of fear that suppresses resistance and disclosure. One of the most common questions healthcare providers may have is why victims stay in or return to abusive relationships. Understanding the multiple barriers to leaving helps providers respond with empathy rather than frustration and provide realistic support. On average, victims attempt to leave abusive relationships 7 times before leaving permanently, and leaving is often the most dangerous time for victims. Fear represents one of the most significant barriers. Victims accurately perceive that leaving may escalate the abuser's violence. Research demonstrates that risk of lethal violence increases substantially when victims attempt to leave, and many domestic violence homicides occur during separation or in the period immediately following. Victims may also fear retaliation against children, family members, or pets. Economic factors create practical barriers to leaving. Victims may lack independent income, savings, or credit. The cost of establishing separate housing, particularly in areas with high cost of living, may be prohibitive. Victims may fear inability to support themselves and their children financially, particularly if the abuser has sabotaged their employment or education. Emotional attachment and hope for change keep many victims in relationships. Despite the abuse, victims may still love their partners and remember positive aspects of the relationship. The honeymoon phase reinforces hope that the abuser can change. Victims may believe the abuse is temporary, related to fixable problems like substance use or their own fault for triggering the abuser's behavior. Children complicate decisions about leaving. Victims may want children to have 2 parents, fear being unable to support children alone, or worry that leaving will expose children to unsupervised visitation with the abuser. Courts do not always recognize domestic violence in custody determinations, and abusers frequently use the legal system to maintain control. Cultural and religious factors may influence victims' decisions. Some communities emphasize family preservation and may stigmatize divorce or separation. Victims may face pressure from family or religious leaders to remain in the relationship. Cultural norms about gender roles, privacy, or appropriate responses to family conflict may discourage disclosure or help seeking. Immigration status creates unique vulnerabilities for immigrant victims. Fear of deportation, uncertainty about rights, language barriers, and lack of familiarity with systems may prevent help seeking. Abusers may threaten to report undocumented victims to immigration authorities, withhold immigration documents, or claim that victims will be deported if they seek help. Healthcare providers should recognize that leaving an abusive relationship is a process rather than an event. Victims may not be ready to leave when providers identify abuse, and this does not indicate intervention failure. Providing information, expressing concern, and connecting victims with resources plant seeds that may bear fruit when victims are ready to take action. Healthcare providers should be alert to warning signs that may indicate a patient is experiencing domestic violence. Physical indicators include injuries inconsistent with stated cause, injuries in various stages of healing, injuries in central body locations typically covered by clothing, and patterns of injuries over time. However, many victims never present with injuries, making behavioral and contextual indicators equally important. Behavioral indicators include fearfulness, anxiety, depression, evasiveness when asked about injuries or home situation, partner speaking for the patient or refusing to leave the room, frequent appointment cancellations or no-shows, and delayed presentation for care. Patients may minimize injuries, express fear of partner's reaction to medical recommendations, or show excessive concern about what information will be documented. Contextual factors that may raise suspicion include frequent emergency department visits, multiple providers or facilities, chronic pain conditions without clear etiology, mental health symptoms, particularly anxiety, depression, or PTSD, substance use, and frequent pregnancy or reproductive health concerns. While none of these indicators alone confirms domestic violence, patterns should prompt appropriate screening and assessment. Specific injury patterns associated with domestic violence include bruising to the head, neck, face, and trunk, defense injuries to the forearms and hands, grip marks on the upper arms, and injuries during pregnancy, particularly to the abdomen and breasts. Multiple injuries at different stages of healing suggest repeated violence over time. Bilateral injuries affecting both sides of the body may suggest defensive posturing during assault. Indicators in the waiting room and during registration may also raise concerns. Partners who insist on accompanying the patient everywhere, who answer questions directed to the patient, who appear controlling or dismissive, or who monitor the patient closely, may be exhibiting concerning behaviors. Staff should be trained to recognize these patterns and facilitate private time with patients. Healthcare providers should understand that trauma affects victims' presentation and behavior in ways that may be misinterpreted. Trauma responses include fight, flight, freeze, and fawn responses that represent adaptive survival mechanisms in dangerous situations. These responses may continue to affect victims' behavior long after immediate danger has passed. The freeze response may cause victims to appear calm, compliant, or emotionally flat when discussing their abuse. This should not be interpreted as lack of concern or evidence that the situation is not serious. Similarly, the fawn response, which involves trying to please or appease the threatening person, may cause victims to defend their abusers or minimize the severity of abuse. Dissociation, a psychological defense that creates distance from overwhelming experiences, may cause victims to appear detached, confused about details, or to provide inconsistent accounts. Providers should recognize dissociation as a trauma response rather than evidence of fabrication or unreliability. Trauma bonding refers to the strong emotional attachment that can develop between victims and their abusers as a result of cycles of abuse and reconciliation. This attachment may cause victims to return to abusive relationships, defend their abusers, or be reluctant to take action. Understanding trauma bonding helps providers respond with patience rather than frustration when victims make decisions that may seem counterintuitive. Module 3: Health Consequences of Domestic Violence. Having examined the dynamics of domestic violence, let us now turn to the profound health consequences that domestic violence inflicts on survivors. Research demonstrates that intimate partner violence is associated with a wide range of acute injuries, chronic health conditions, mental health disorders, and adverse reproductive outcomes. Healthcare providers must understand these associations to recognize presentations that may indicate abuse and appreciate the comprehensive health burden experienced by survivors. Survey data reveal that intimate partner violence-related impacts include physical injuries, need for medical care, concern for safety, symptoms of post-traumatic stress disorder, and need for legal, housing, and victim advocacy services. A systematic review and meta-analysis examining data from over 250,000 women documented significantly increased odds of depression, anxiety, PTSD, and suicidality among intimate partner violence survivors compared to those without such exposure. Physical injuries from domestic violence range from minor bruises to fatal trauma. Common acute injuries include contusions, lacerations, fractures, head injuries, and internal organ damage. Injury patterns in domestic violence often differ from accidental injuries, with central body locations such as the head, neck, face, chest, abdomen, and genitals more commonly affected than extremities. Radiological imaging studies have documented characteristic injury patterns in intimate partner violence victims, including facial fractures, particularly orbital and nasal fractures, rib fractures, and injuries to breasts and genitals. Multiple injuries in various stages of healing, bilateral injuries, and defensive injuries to forearms and hands may also suggest abuse rather than accidental trauma. Healthcare providers should maintain clinical suspicion when injury patterns are inconsistent with stated mechanism, when patients present repeatedly with injuries, or when there are delays in seeking care. Documentation of injuries, which we will discuss in detail in a later module, is critical for both medical treatment and potential legal proceedings. Non-fatal strangulation represents one of the most dangerous forms of domestic violence and a significant predictor of future lethal violence. Strangulation, often incorrectly called choking, involves external compression of the neck structures, resulting in restricted blood flow to the brain or restricted breathing. Research indicates that prior strangulation increases the risk of subsequent homicide by a factor of 7. The health consequences of strangulation extend far beyond visible neck injuries, which may be minimal or absent. Even brief strangulation can cause hypoxic brain injury with lasting neurological consequences. Research has found that among female intimate partner violence survivors, over 35% reported intimate partner violence-related traumatic brain injury, over 76% reported subconcussive injury, and over 31% reported at least one episode of attempted strangulation. Another study found that over 92% of intimate partner violence survivors reported indicators of potential hypoxic brain injury from strangulation. Symptoms of strangulation may include voice changes, difficulty swallowing, neck pain, respiratory symptoms, and neurological symptoms such as memory problems, confusion, and changes in sensation or motor function. Many symptoms may not appear immediately but develop hours to days after the assault. Healthcare providers examining patients who report strangulation should be aware of the potential for delayed presentation of serious complications, including stroke and airway compromise. Neuropathological research has documented structural brain changes in intimate partner violence survivors related to both direct trauma and strangulation, documenting evidence of vascular and white matter pathologies, iron deposition, and microgliosis. These findings underscore the serious long-term consequences of repetitive head trauma and strangulation in domestic violence. The health impacts of domestic violence extend far beyond acute injuries. Intimate partner violence is associated with numerous chronic health conditions that may persist long after the abuse has ended. Research analyzing survey data has found significant associations between intimate partner violence and chronic conditions, including asthma, diabetes, high cholesterol, heart disease, stroke, and chronic pain. Chronic pain syndromes are particularly common among intimate partner violence survivors. Headaches, back pain, pelvic pain, and fibromyalgia occur at elevated rates in this population. These conditions may result from direct injury, psychophysiological stress responses, or both. Providers treating patients with chronic pain should consider domestic violence in their differential diagnosis, particularly when pain is diffuse, difficult to characterize, or refractory to standard treatments. Gastrointestinal symptoms including irritable bowel syndrome, nausea, appetite changes, and functional gastrointestinal disorders are significantly more common among intimate partner violence survivors. Cardiovascular conditions including hypertension and heart disease are also associated with intimate partner violence exposure. These associations may reflect both direct injury and the physiological effects of chronic stress, including sustained activation of the hypothalamic pituitary adrenal axis. The mental health consequences of domestic violence are profound and well documented. A comprehensive systematic review and meta-analysis examined 201 studies encompassing over 250,000 women and found that intimate partner violence was significantly associated with increased odds of depression, with odds ratios ranging from about 2 to 3. Anxiety with odds ratios ranging from about 2.25 to 3. PTSD with odds ratios ranging from about 2.15 to 2.66, and suicidality with odds ratios ranging from about 2.17 to 5.5. Post-traumatic stress disorder is particularly prevalent among intimate partner violence survivors. The traumatic nature of domestic violence, combined with its typically repetitive character and betrayal by an intimate partner, creates conditions highly conducive to PTSD development. Symptoms include intrusive re-experiencing of trauma, avoidance of reminders, negative alterations in cognition and mood, and hyperarousal. A meta-analysis examining perinatal intimate partner violence found that 30% of women experiencing intimate partner violence during pregnancy develop PTSD. Depression affects a substantial proportion of intimate partner violence survivors. Symptoms may include persistent sadness, loss of interest or pleasure, changes in appetite and sleep, fatigue, feelings of worthlessness or guilt, difficulty concentrating, and thoughts of death or suicide. Depression may be compounded by the isolation, economic stress, and loss of self-efficacy that often accompany abusive relationships. Anxiety disorders, including generalized anxiety disorder, panic disorder, and social anxiety, occur at elevated rates among domestic violence survivors. The chronic stress of living in fear, uncertainty about safety, and hypervigilance required for survival contribute to the development of anxiety symptoms. Anxiety may persist long after the abusive relationship has ended. Substance use disorders occur at elevated rates among intimate partner violence survivors and may represent attempts to cope with trauma, pain, or mental health symptoms. Substance use may also be coerced by abusers or used as a tool of control. Healthcare providers should assess for substance use among patients who may be experiencing domestic violence while recognizing that substance use does not cause or excuse abuse. Dissociative symptoms, including depersonalization, derealization, and dissociative amnesia, may occur in domestic violence survivors as psychological defenses against overwhelming trauma. Providers should be aware of dissociative presentations and understand that apparent lack of emotional response may reflect trauma response rather than lack of concern about the situation. Cochrane systematic reviews have examined psychological interventions for intimate partner violence survivors. One review examined 33 trials with over 5,500 participants and found evidence supporting various psychological therapies for addressing mental health consequences of intimate partner violence. Trauma-informed care approaches, which we will discuss further in the next module, are essential for appropriately addressing the mental health needs of this population. Domestic violence has significant implications for reproductive health. Reproductive coercion, including birth control sabotage, pregnancy coercion, and pregnancy pressure, is common in abusive relationships. Unintended pregnancy, repeat abortion, sexually transmitted infections, and gynecological problems all occur at elevated rates among intimate partner violence survivors. pregnancy is a particularly vulnerable time for domestic violence. While some studies suggest that pregnancy may be protective against intimate partner violence, others indicate that violence may begin or escalate during pregnancy. An umbrella review of perinatal domestic violence literature documented significant risks associated with intimate partner violence during pregnancy. A meta-analysis of 17 studies found that intimate partner violence during pregnancy significantly predicted low birth weight, with an adjusted odds ratio of about 3.7, and preterm birth, with an adjusted odds ratio of about 2.2. The American College of Obstetricians and Gynecologists recommends screening for intimate partner violence at least once each trimester and at the postpartum visit. Prenatal care provides regular opportunities for screening and intervention in a setting where pregnant patients typically have privacy from partners. Healthcare providers should be particularly alert to warning signs during pregnancy and ensure that pregnant patients have opportunities for confidential conversation. The postpartum period represents continued risk. New parents face additional stressors that may exacerbate relationship conflict. Breastfeeding, infant care, and recovery from childbirth may create opportunities for control or abuse. Screening should continue during postpartum visits, and providers should be alert to signs of abuse affecting new mothers. Children exposed to domestic violence experience significant adverse effects even when they are not direct targets of abuse. Witnessing violence between parents or caregivers is recognized as an adverse childhood experience associated with increased risk of behavioral problems, emotional difficulties, developmental delays, and long-term health consequences. Children may be exposed to domestic violence through direct witnessing, hearing violence, observing injuries or aftermath, being used as pawns in the abuse, or experiencing the effects of trauma on their abused parent. The effects vary by age, developmental stage, frequency and severity of exposure, and protective factors. However, research consistently demonstrates that children in homes with domestic violence are at elevated risk for negative outcomes. Neurocognitive impacts of childhood exposure to violence have been documented in research examining the cycle of victimization. A systematic scoping review examining associations between child maltreatment, peer victimization, and mental health outcomes found evidence of lasting neurobiological effects. These findings underscore the importance of addressing family violence comprehensively. The intergenerational transmission of violence is well documented. Children who witness domestic violence or experience direct abuse are at increased risk of becoming perpetrators or victims in their own adult relationships. Healthcare providers working with families should recognize the potential for intergenerational patterns and the importance of intervention to break these cycles. Florida law requires healthcare providers to report suspected child abuse, including situations where children are exposed to domestic violence under certain circumstances. We will address mandatory reporting requirements in detail in the module on documentation and legal considerations. Providers should be familiar with their reporting obligations while also recognizing that mandatory reporting can create complex situations for adult victims seeking to protect their children. Module 4: Screening and Assessment. Now that we have examined the health consequences of domestic violence, let us turn to the practical skills of screening and assessment. Universal screening for domestic violence represents best practice for healthcare settings. Rather than relying on clinical suspicion or risk factor assessment to determine which patients to screen, universal screening asks all patients about intimate partner violence regardless of presentation or demographic characteristics. This approach recognizes that domestic violence affects individuals across all populations and that victims may not present with obvious warning signs. The U.S. Preventive Services Task Force has examined the evidence for intimate partner violence screening in healthcare settings. The most recent systematic review examined 35 studies with over 18,000 participants and found that screening tools demonstrate adequate accuracy for detecting intimate partner violence, with sensitivity ranging from 26% to 87%, and specificity from 80% to 97%, depending on the tool used. Evidence suggests that screening increases identification of intimate partner violence and that interventions following screening can reduce intimate partner violence and improve health outcomes. An implementation-focused systematic review examined intimate partner violence screening programs delivered by clinical staff in real-world healthcare settings and found that screening programs achieved median reach of 80% of eligible patients, with 11% screening positive for intimate partner violence. These findings demonstrate that universal screening is feasible to implement in clinical practice and identifies a meaningful proportion of patients experiencing abuse. Before screening can be effective, healthcare providers must create an environment conducive to disclosure. Victims are unlikely to disclose abuse if they do not feel safe, if their abuser is present, or if they do not trust confidentiality. Attention to environmental factors and communication approaches significantly affects disclosure rates. Private conversation is essential for intimate partner violence screening. Patients should be asked about domestic violence only when they are alone, without partners, family members, or friends present. Healthcare settings should establish protocols that ensure private time with all patients. Staff should be trained on techniques for separating patients from companions, such as explaining that it is clinic policy to speak with patients privately about sensitive health matters. Physical environment considerations include ensuring privacy, posting information about domestic violence resources in locations visible to patients but not companions, such as restrooms, and making hotline numbers available in discrete formats. Patients should be able to access information without their companion's knowledge. Cultural and linguistic considerations affect disclosure. Providers should be prepared to work with interpreters when needed, recognizing that professional medical interpreters are preferable to family members or friends who may have their own interests or may share information with the abuser. Cultural humility and awareness of how domestic violence may be understood in different communities helps create a welcoming environment for diverse patients. Several validated screening tools are available for intimate partner violence screening in healthcare settings. These tools have been tested for their ability to identify intimate partner violence accurately and efficiently in clinical contexts. Selection of a screening tool should consider the practice setting, patient population, time available, and provider training. The HITS tool is a 4-item screening instrument that asks about frequency of partner behaviors, including physical hurt, insults, threats, and screaming. The acronym HIT stands for Hurt, Insult, Threaten, and Scream. Each item is scored on a 5-point frequency scale, with total scores above 10 suggesting intimate partner violence. HITS has been validated in multiple populations and is brief enough for routine use. The abuse assessment screen consists of 5 questions addressing physical abuse, abuse during pregnancy, and fear of partner. Originally developed for use in obstetric settings, the abuse assessment screen has been validated in various clinical populations. Its inclusion of a pregnancy-specific question makes it particularly useful for prenatal screening. The partner violence screen is a 3-item tool that can be administered in approximately 20 seconds. Questions address physical violence in the past year, safety in current relationship, and whether a current or former partner has caused physical harm. Its brevity makes it suitable for busy clinical settings where time is limited. The woman abuse screening tool includes 8 items addressing relationship tension, difficulty resolving arguments, regret over arguments, frightening behavior, and various forms of abuse. Both a short form with 2 items and the full version have been validated. The woman abuse screening tool has demonstrated good sensitivity and specificity for detecting intimate partner violence. The STAT screening tool consists of 3 questions. Have you ever been slapped, kicked, or otherwise physically hurt by your partner? Have you ever been threatened with physical harm by your partner? And have you ever been forced into talking about things you didn't want to discuss? Research supports its utility as a brief screening instrument. A systematic review evaluating the measurement properties of intimate partner violence screening instruments found variable psychometric quality across tools. The selection of a screening tool should consider validation evidence, appropriate cutoff scores for the population being screened, and practical considerations such as administration time and format. Trauma-informed care provides an essential framework for intimate partner violence screening and response. This approach recognizes the widespread prevalence of trauma, understands its impacts on health and behavior, integrates knowledge about trauma into policies and practices, and actively avoids re-traumatization. For intimate partner violence survivors, trauma-informed care means that every interaction acknowledges their potential trauma history and prioritizes safety, trustworthiness, and empowerment. Key principles of trauma-informed care include safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and sensitivity to cultural, historical, and gender issues. Applied to intimate partner violence screening, these principles guide providers to create physically and emotionally safe environments, be clear about confidentiality and its limits, involve patients in decision-making, and respect patient autonomy. A meta-analysis examining trauma-informed care outcomes found evidence supporting the effectiveness of trauma-informed approaches for improving mental health outcomes. One analysis examined 13 randomized controlled trials with 850 participants and documented benefits of trauma-informed interventions for individuals with trauma histories. Cochrane systematic reviews have examined training healthcare providers on intimate partner violence identification and response. One review examined 19 trials with over 1,600 participants and found that training can improve providers' knowledge, attitudes, and behaviors related to intimate partner violence. However, effectiveness depends on training quality, organizational support, and system-level factors. Training alone without supportive policies and resources may be insufficient. When a patient discloses intimate partner violence or screens positive, the immediate provider response significantly affects the patient's experience and subsequent actions. An empathetic, non-judgmental response validates the patient's experience and opens the door for further conversation and support. Providers should express concern for safety, affirm that abuse is not the patient's fault, and offer resources and referrals without pressure to take specific actions. Specific language that communicates support includes phrases such as, "Thank you for telling me about this. I know that wasn't easy to share. I'm concerned about your safety. You don't deserve to be treated this way. This is not your fault. I want you to know that help is available whenever you're ready." Providers should avoid questions that imply blame such as, "What did you do?" or "Why do you stay?" Assessment following disclosure should include evaluation of immediate safety, presence of injuries requiring treatment, mental health status, and need for immediate resources. Providers should ask directly about safety. Are you safe to go home? Is your partner here today? Do you have a safe place to stay if you need one? Answers to these questions guide the urgency and nature of the response. Despite evidence supporting universal screening, significant barriers prevent consistent implementation. A systematic review examining barriers to prenatal intimate partner violence screening identified provider-level barriers including time constraints, lack of training, discomfort with the topic, and uncertainty about how to respond to disclosure. System-level barriers include lack of protocols, inadequate resources for referral, and competing clinical priorities. Patients face their own barriers to disclosure. Fear of consequences, including retaliation from the abuser, involvement of child protective services, or judgment from providers, may prevent disclosure. Shame, self-blame, and minimization of abuse are common psychological barriers. Cultural factors, language differences, and lack of trust in systems may affect disclosure among diverse populations. Healthcare providers can address many barriers through appropriate training, supportive organizational policies, and available referral resources. Providers should be trained not only on how to screen but also on how to respond to disclosure, including immediate safety assessment, appropriate documentation, and connection to resources. Having clear protocols and readily available referral information facilitates provider comfort and effectiveness. Documentation of intimate partner violence screening should be handled thoughtfully, balancing the need for medical record completeness with patient safety concerns. Screening results should be documented in a manner that is consistent with organizational policy and appropriate for the patient's circumstances. When screening is negative, documentation typically notes that screening was conducted and denied by the patient. When screening is positive or intimate partner violence is disclosed, documentation must balance the clinical need to record relevant information with potential risks if the abuser accesses medical records. Electronic health records may include features that flag domestic violence history or restrict access to sensitive information. Providers should be familiar with their system's capabilities and organizational policies regarding documentation of intimate partner violence. In all cases, documentation should be factual, objective, and avoid language that could be used against the patient. Successful implementation of universal intimate partner violence screening requires attention to workflow integration, provider training, and system support. Screening should be incorporated into routine clinical processes rather than treated as an optional add-on. Many healthcare systems include intimate partner violence screening questions in intake forms, nursing assessments, or electronic health record prompts that remind providers to address this topic. Provider training should address not only how to ask screening questions, but also how to respond to disclosure, assess immediate safety, provide appropriate support, and make referrals. Providers who lack confidence in their ability to respond effectively may be reluctant to screen, making response training essential. Role-playing exercises and case-based training can build provider competence and comfort. System-level support includes having referral resources readily available, ensuring that staff know who to contact for assistance with complex cases, and creating a culture that recognizes intimate partner violence response as a core clinical responsibility rather than an optional activity. Quality improvement processes should monitor screening rates and identify opportunities for improvement. Time constraints represent a significant barrier in busy clinical settings. Brief screening tools that can be administered in under 1 minute help address this barrier. Additionally, recognizing that disclosure often does not occur on the first screening attempt, consistent brief screening over time may ultimately be more effective than extensive but inconsistent assessment. Module 5: Documentation and Legal Considerations. Having learned how to screen for and respond to domestic violence disclosures, we must now understand the legal framework governing documentation and reporting in Florida. Healthcare providers in Florida operate within a specific legal framework that governs documentation of domestic violence, reporting obligations, and confidentiality protections. Understanding this framework is essential for fulfilling professional responsibilities while supporting patient safety and autonomy. Florida law establishes mandatory reporting requirements for certain populations while generally preserving adult victims' right to confidentiality and self-determination. Florida Statutes Section 456.031 establishes the requirement for healthcare provider education on domestic violence and specifies content that must be included in approved courses. This statute reflects legislative recognition of healthcare providers' important role in identifying and responding to domestic violence. The educational requirements exist to ensure that licensed healthcare professionals possess the knowledge and skills necessary to fulfill this role effectively. A critical distinction in domestic violence legal requirements is between mandatory and permissive reporting. In Florida, healthcare providers generally are not required to report domestic violence involving competent adult victims without their consent. Adult victims have the right to make their own decisions about reporting to law enforcement, and healthcare providers should respect patient autonomy in this regard. However, certain circumstances trigger mandatory reporting obligations regardless of the victim's wishes. These mandatory reporting situations include suspected child abuse or neglect, including situations where children are exposed to domestic violence, suspected abuse, neglect, or exploitation of vulnerable adults, including elderly individuals and adults with disabilities, and injuries caused by certain mechanisms such as gunshot wounds and injuries from other violent acts as specified in Florida statutes. When mandatory reporting applies, healthcare providers must make reports regardless of the adult victim's preferences. This can create tension between legal obligations and patient trust. Providers should inform patients about reporting obligations and explain that certain reports are required by law. Transparency about mandatory reporting preserves trust even when reports must be made against patient wishes. Florida Statute Section 39.201 establishes mandatory reporting requirements for suspected child abuse, abandonment, or neglect. Healthcare providers and other mandated reporters must report to the Florida Abuse Hotline when they have reasonable cause to suspect that a child has been abused, abandoned, or neglected. This obligation applies regardless of whether the information was obtained in a professional capacity. Children's exposure to domestic violence may constitute child abuse or neglect under certain circumstances. When children witness violence, are injured during violent incidents, or are otherwise affected by domestic violence in the home, reporting may be required. Providers should consult with their organization's policies and, when necessary, legal counsel to determine reporting obligations in specific situations. Reports to the Florida Abuse Hotline can be made by telephone at 1-800-962-2873 or through the online reporting system. Reports should include identifying information about the child and family, the nature of the suspected abuse or neglect, and any information relevant to child safety. Reporters are immune from liability when reports are made in good faith. Healthcare providers should recognize that mandatory child abuse reporting can create complex situations for adult domestic violence victims. Victims may fear that reporting will result in loss of custody, further violence from the abuser, or other negative consequences. Providers should address these concerns honestly while fulfilling legal obligations and offering support and resources to adult victims. The intersection of domestic violence and child welfare creates situations where adult victims may simultaneously be protective parents and subjects of Child Protective Services investigation. Providers should understand that non-offending parents in domestic violence situations are often doing their best to protect their children under difficult circumstances. Supportive approaches that recognize this complexity are more effective than punitive responses that may further endanger families. Training specifically addressing the intersection of domestic violence and child welfare, such as that provided through the Green Book Initiative and similar frameworks, can help providers navigate these complex situations. Key principles include holding batterers accountable rather than blaming victims, supporting protective parents, and ensuring that system responses do not increase danger to children or their non-abusing parents. Florida Statute Section 415.1034 establishes mandatory reporting requirements for suspected abuse, neglect, or exploitation of vulnerable adults. Vulnerable adults include elderly individuals, age 65 and older, and adults with disabilities that impair their ability to protect themselves. Healthcare providers must report suspected abuse of vulnerable adults to the Florida Abuse Hotline. Abuse of vulnerable adults in domestic violence contexts may involve intimate partners, family members, or caregivers. Signs of abuse may include unexplained injuries, poor hygiene, malnutrition, dehydration, untreated medical conditions, withdrawal, and fear of caregivers. Financial exploitation, a common form of elder abuse, may co-occur with domestic violence. When vulnerable adult abuse is suspected in a domestic violence context, providers must balance mandatory reporting obligations with recognition that the vulnerable adult may be at ongoing risk from the abuser. Safety planning and connection to resources remain important components of the response, even when mandatory reports are required. Thorough, objective documentation serves multiple purposes in domestic violence cases. Medical records provide evidence for potential legal proceedings, document the pattern of abuse over time, support victims' credibility, and guide ongoing medical care. The National Institute of Justice has developed guidance on documentation that healthcare providers should follow. Documentation should use the patient's own words whenever possible, placed in quotation marks. Descriptions of events should be attributed to the patient with language such as patient states or patient reports. This approach preserves the patient's account accurately while making clear that the information comes from the patient rather than provider observation or assumption. Physical findings should be documented in detail using objective, descriptive language. Rather than stating the patient was beaten, documentation should describe specific injuries including location, size, shape, color, and any patterns. Body diagrams can supplement written descriptions. Photography, when available and consented to, provides valuable documentation of injuries. Documentation should avoid conclusions about the source of injuries unless directly observed. Terms like alleged perpetrator may be used when describing the patient's account of who caused injuries. Documentation should never blame the victim, minimize the abuse, or include judgmental language. Comments about the victim's credibility, sobriety, or behavior should be avoided unless directly relevant to clinical care. Strangulation documentation requires particular attention given the potential for delayed serious complications and the significance of strangulation as a risk factor for lethality. Providers should document the mechanism described by the patient, any symptoms during or after the assault, physical findings on examination, and any imaging or other diagnostic studies. Even in the absence of visible injury, documented patient report of strangulation is significant. Dating of injuries can be relevant in legal proceedings. When possible, providers should note the patient's report of when injuries occurred and any clinical observations about injury age, such as the healing stage of bruising. However, providers should acknowledge limitations in determining injury timing and avoid overconfident conclusions. The Health Insurance Portability and Accountability Act, known as HIPAA, establishes standards for protecting patient health information. In domestic violence contexts, confidentiality is particularly important because disclosure of information could endanger victims or alert abusers to victims' help seeking. Healthcare providers must understand how HIPAA applies to domestic violence situations. HIPAA permits disclosure of protected health information without patient authorization in specific circumstances, including when required by law, such as mandatory reports, and to prevent or lessen a serious and imminent threat to health or safety. However, permissive disclosures should be carefully considered given potential risks to victim safety. Patients may request restrictions on disclosure or communication of their health information. Domestic violence victims may request that communications not be sent to their home address or phone, that certain information not be disclosed to their insurance, or that specific individuals not have access to their information. Providers should accommodate reasonable requests to protect victim safety. Electronic health records create specific considerations. Patients may have online portal access that abusers could potentially access. Practices should consider how to protect sensitive information in electronic systems and should counsel patients about account security. Features that allow patients to see test results, notes, or messages may need to be addressed in domestic violence situations. Healthcare providers play an important role in preserving evidence that may be used in criminal or civil legal proceedings. While providers are not law enforcement investigators, attention to evidence preservation during routine care can significantly support victims' legal options. Clothing and other physical evidence should be handled according to institutional protocols. Victims should be advised not to wash, change clothes, or clean up before examination if possible, particularly in cases of sexual assault. When clothing is collected, it should be placed in paper bags, not plastic, which can degrade biological evidence, and handled according to chain of custody requirements. Photographic documentation of injuries should follow institutional protocols. Photographs should include identification information, be taken from multiple angles, include a ruler or other scale reference, and be stored securely. Patients should provide written consent for photographs, understanding that they may be used in legal proceedings. Forensic examinations, including sexual assault nurse examiner examinations, may be appropriate in some domestic violence cases, particularly those involving sexual assault. Providers should be familiar with resources for forensic examination in their community and protocols for referral. Victims should be informed of their options for evidence collection, understanding that they can choose whether to pursue legal action later. Chain of custody refers to the documentation of evidence handling from collection through analysis and court presentation. Healthcare providers who collect evidence should follow institutional protocols for maintaining chain of custody, including documentation of who collected evidence, when and how it was stored and transferred. Proper chain of custody is essential for evidence to be admissible in court proceedings. Healthcare providers may be called to testify in legal proceedings involving domestic violence, including criminal trials, civil protection order hearings, and custody proceedings. Providers should understand their potential role as witnesses and be prepared to provide accurate, objective testimony based on their clinical documentation. Testimony typically focuses on what the provider observed, documented, and concluded based on clinical examination. Providers should testify only to matters within their knowledge and expertise, acknowledging limitations when appropriate. Documentation created at the time of clinical encounters forms the foundation for testimony, making thorough contemporaneous documentation essential. Providers called to testify should review their documentation prior to testimony, consult with their institution's legal counsel if needed, and be prepared to explain clinical findings in language accessible to non-medical audiences. Expert witness testimony on topics such as domestic violence dynamics or medical findings may require additional qualifications beyond treating provider testimony. Module 6: Intervention and Referral. Understanding the legal framework leads us naturally to the practical skills of intervention and referral. When a patient discloses domestic violence or screens positive for intimate partner violence, the healthcare provider's immediate response sets the tone for the entire interaction. An empathetic, supportive response validates the patient's experience, builds trust, and opens opportunities for further conversation and intervention. Conversely, dismissive, judgmental, or pushy responses may cause victims to minimize their situation, decline assistance, or disengage from healthcare. Initial response should acknowledge the disclosure, express concern for the patient's safety, and affirm that abuse is not the patient's fault. Simple statements such as, "Thank you for telling me, I'm concerned about your safety, and you don't deserve to be treated this way," communicate support without judgment. Providers should avoid asking why the patient stays, expressing disbelief, or criticizing the abuser in ways that may prompt the patient to defend the relationship. Assessment of immediate safety is the first priority. Providers should ask whether the patient is in immediate danger, whether it is safe to return home, and whether there are weapons in the home. If the patient is in immediate danger, assistance should be offered to contact law enforcement or domestic violence services. Even patients not in immediate danger should be assessed for ongoing risk and connected with resources. Danger assessment tools help identify victims at elevated risk for severe violence or homicide. The most widely used instrument, the danger assessment developed by Jacqueline Campbell, evaluates risk factors including history of violence, weapons access, threats, strangulation, substance abuse, and separation status. Elevated scores indicate need for intensive safety planning in immediate connection to domestic violence services. A systematic review of risk assessment instruments for intimate partner femicide has documented the predictive validity of various tools. Key risk factors consistently identified include prior strangulation, access to firearms, threats to kill, escalating violence, and separation or attempts to leave. Healthcare providers should be alert to these risk factors even when formal danger assessment is not conducted. Implementation of danger assessment in healthcare settings has been studied in emergency department contexts. Research has found that systematic screening and assessment increased identification of high-risk victims and connection to services. Integration of danger assessment into clinical protocols can improve outcomes for domestic violence survivors. Culturally adapted danger assessment tools have been developed for diverse populations, including validated adapted instruments for immigrant and refugee women. Healthcare providers working with diverse populations should be aware of culturally specific risk factors and available adapted tools. Safety planning is a critical intervention that helps domestic violence victims increase their safety whether or not they choose to leave the relationship immediately. Safety plans are personalized strategies that address the specific circumstances and resources of each individual victim. Healthcare providers can support safety planning by discussing key elements and connecting patients with domestic violence advocates who can provide comprehensive assistance. Safety planning for patients remaining in the relationship may include recognizing warning signs of escalation, identifying safer places within the home during acute incidents, establishing code words with trusted contacts, keeping important documents and emergency supplies accessible, and knowing hotline numbers and local resources. Plans should be realistic given the victim's specific circumstances and should not increase danger. Safety planning for separation requires additional considerations. Leaving is often the most dangerous time for domestic violence victims, and planning can reduce risk. Elements may include safe timing and method for leaving, safe places to go, protective orders, custody and visitation arrangements, financial preparation, and strategies for maintaining safety after separation. Domestic violence advocates are expert resources for separation safety planning. Technology safety has become an increasingly important component of safety planning. Abusers may monitor victims through GPS tracking, spyware, shared accounts, and social media. Safety planning should address technology security, including phone and computer privacy, account access, and safe communication methods. Victims should be counseled about risks of using devices the abuser may access. Specific technology safety considerations include checking phones and devices for tracking apps or spyware, creating new email accounts not known to the abuser, changing passwords on all accounts, adjusting privacy settings on social media, being cautious about location sharing features, using a safe computer at a library or trusted friend's home for sensitive searches, and understanding that deleted messages may be recoverable. Victims should be informed that abusers may have technological sophistication that enables monitoring even when victims believe they have privacy. Safety planning should address the safety of pets, as research demonstrates that abusers frequently harm or threaten to harm family pets as a tactic of control, and concern for pet safety may prevent victims from leaving. Some domestic violence shelters now accommodate pets, and pet safekeeping programs exist in many communities. Healthcare providers should ask about pets and include pet safety and safety planning discussions. Florida has 42 certified domestic violence centers that provide comprehensive services to victims and their families. These centers are certified by the Florida Department of Children and Families and receive state funding to provide emergency shelter, counseling, case management, legal advocacy, and other services. Healthcare providers should be familiar with the certified center serving their geographic area. Services provided by certified centers include 24-hour crisis hotlines, emergency shelter for victims and their children, individual and group counseling, case management, legal advocacy, including assistance with injunctions for protection, children's services, and community education. Many centers also provide transitional housing, economic empowerment programs, and specialized services for underserved populations. The Florida Coalition Against Domestic Violence, now known as the Florida Partnership to End Domestic Violence, coordinates the statewide network of certified centers and maintains resources including a statewide hotline. Healthcare providers can refer patients to the statewide hotline at 1-800-500-1119 or connect patients with their local certified center. Referral to domestic violence services should be offered but not forced. Patients have the right to decline referrals, and pressure to accept services may be counterproductive. Providers can offer information about services, provide hotline numbers and materials to take home, and let patients know that services are available whenever they are ready. Warm referrals, where the provider facilitates direct connection with an advocate, may increase service engagement. In addition to Florida-specific resources, national organizations provide valuable services and information. The National Domestic Violence Hotline, which can be reached at 1-800-799-7233, operates 24 hours a day, 7 days a week, and provides crisis intervention, safety planning, and referrals to local resources. The hotline is available in English and Spanish with access to translation services for other languages. The hotline also offers chat and text options for individuals who cannot safely make phone calls. The National Coalition Against Domestic Violence, Futures Without Violence, and other national organizations provide educational materials, training resources, and policy information relevant to healthcare providers. These organizations maintain websites with resources including downloadable patient education materials, provider training modules, and research summaries. For patients experiencing intimate partner sexual violence, sexual assault service providers, including rape crisis centers, offer complementary services. Many communities have both domestic violence centers and sexual assault programs, and some have programs that address both. Healthcare providers should be familiar with local resources for comprehensive referral. The Office on Violence Against Women within the U.S. Department of Justice provides funding for domestic violence programs nationwide and maintains resources on evidence-based practices. The Centers for Disease Control and Prevention's violence prevention resources include data, research, and prevention strategies. Healthcare providers seeking to deepen their knowledge can access these federal resources for additional information and training opportunities. Domestic violence victims have access to various legal remedies that healthcare providers should understand at a general level. Injunctions for protection, commonly known as restraining orders, are civil court orders that can prohibit contact, require the abuser to leave a shared residence, and address custody and support. Victims can petition for injunctions without an attorney, and domestic violence centers provide legal advocacy to assist with this process. Criminal prosecution of domestic violence is handled by state attorneys' offices. Victims can report to law enforcement, who investigate and may make arrests. However, prosecution decisions are made by prosecutors, and victims cannot simply drop charges. Healthcare providers should understand that victims may have complex feelings about criminal justice involvement and should support patient autonomy in this area. Immigration relief options exist for immigrant victims of domestic violence. The Violence Against Women Act provides pathways to legal status for victims of abuse by U.S. citizen or permanent resident spouses. U visas are available for victims of qualifying crimes, including domestic violence, who have been helpful to law enforcement. Immigration legal assistance should be included in referrals for immigrant victims. Healthcare providers can provide ongoing support to domestic violence survivors beyond the initial disclosure and referral. Follow-up appointments provide opportunities to reassess safety, review and update safety plans, address health consequences of abuse, and maintain supportive relationships with patients who may not be ready to take action. Patients who are not ready to leave or access services still benefit from healthcare provider support. Maintaining a non-judgmental, supportive relationship keeps the door open for future help seeking. Providers can continue to provide information, express concern, and offer referrals at subsequent visits. Research indicates that victims often require multiple contacts with supportive systems before taking action. Self-care for healthcare providers is an important consideration when working with domestic violence survivors. Secondary traumatic stress affects providers who hear trauma disclosures and may struggle with patients' difficult circumstances. Providers should have access to support, consultation, and resources for their own well-being when working with this population. Interdisciplinary collaboration enhances domestic violence response. Social workers, case managers, patient advocates, and other professionals may be involved in supporting domestic violence survivors within healthcare settings. Clear communication and coordination among team members ensures comprehensive care. Many healthcare systems employ domestic violence advocates or have formal partnerships with community domestic violence programs. Quality improvement processes should monitor domestic violence screening, identification, and intervention outcomes. Tracking data on screening rates, disclosure rates, referrals made, and referrals completed can identify opportunities for improvement. Regular review of policies and procedures ensures that institutional responses remain current and effective. Healthcare providers may encounter both victims and perpetrators of domestic violence in their practice, sometimes within the same family. While the primary focus of this course is on identifying and supporting victims, providers should be aware of considerations when working with individuals who use violence against intimate partners. Perpetrators may present to healthcare settings for treatment of injuries sustained during violent incidents, for mental health treatment, or for management of conditions such as substance use disorders that may co-occur with domestic violence perpetration. Providers should not assume that individuals presenting with certain characteristics are perpetrators and should maintain therapeutic relationships while recognizing the need to prioritize victim safety. Batterer intervention programs represent the primary treatment approach for domestic violence perpetrators. These programs, distinct from anger management, focus specifically on domestic violence and typically use group formats to address power and control dynamics, promote accountability, and teach nonviolent relationship skills. Healthcare providers may refer perpetrators to certified batterer intervention programs when appropriate. Couples counseling is generally contraindicated when domestic violence is present. Joint counseling may endanger victims who disclose information that the abuser later punishes them for revealing. Furthermore, domestic violence is fundamentally an issue of power and control rather than relationship conflict, making approaches that assume mutual responsibility inappropriate. Providers should avoid recommending couples counseling when domestic violence has been identified. Module 7: Special Populations and Cultural Considerations. Now let us turn our attention to the unique considerations that apply when working with special populations. Effective domestic violence intervention requires culturally responsive approaches that recognize the diverse experiences and needs of different populations. While domestic violence affects individuals across all demographic groups, specific populations may face unique barriers, risk factors, and considerations that influence both their experiences of abuse and their responses to intervention. Healthcare providers must be prepared to provide culturally competent care to all patients. Cultural competence in domestic violence response involves understanding how cultural background may influence victims' experiences and help-seeking behaviors, recognizing barriers faced by specific populations, adapting communication and intervention approaches to meet diverse needs, and connecting patients with culturally appropriate resources. This does not mean stereotyping patients based on demographic characteristics, but rather being prepared to address the specific needs that may arise. Domestic violence occurs in LGBTQ+ relationships at rates equal to or exceeding those in heterosexual relationships, yet these populations face unique barriers to identification and service access. A comprehensive systematic review and meta-analysis examined 85 articles with nearly 50,000 participants and found that transgender individuals are 1.7 times more likely to experience any intimate partner violence, 2.2 times more likely to experience physical intimate partner violence, and 2.5 times more likely to experience sexual intimate partner violence compared to cisgender individuals. LGBTQ+ domestic violence survivors face specific barriers, including fear of discrimination from service providers, fear of outing themselves or their partner, lack of LGBTQ+ inclusive resources, minimization of same-sex intimate partner violence by others, and unique forms of abuse such as threatening to disclose sexual orientation or gender identity. Some abusers leverage societal stigma against LGBTQ+ identities as a tool of control. Healthcare providers serving LGBTQ+ patients should use inclusive language, avoid assumptions about relationships or gender, be familiar with LGBTQ+ affirming resources, and recognize that abuse can occur in any relationship regardless of the genders involved. Screening tools and intake forms should be inclusive of diverse relationship structures and gender identities. Sexual minority men also experience intimate partner violence at significant rates. A rapid systematic review and meta-analysis examining intimate partner violence victimization among sexual minority men documented associations with sexually transmitted infection risk. Healthcare providers should screen male patients in same-sex relationships for intimate partner violence using gender-neutral screening approaches. Immigrant and refugee populations face unique vulnerabilities and barriers related to domestic violence. Documentation status, language barriers, lack of familiarity with U.S. legal and social systems, isolation from support networks, and fear of law enforcement create significant obstacles to help seeking. Abusers may exploit these vulnerabilities by threatening deportation, controlling immigration documents, or leveraging language barriers to maintain control. Healthcare providers should be aware that immigrant victims may have limited English proficiency and require professional interpretation services. Family members should not serve as interpreters for domestic violence discussions due to potential conflicts of interest and safety concerns. Providers should be familiar with immigration-related legal options for domestic violence survivors, including VAWA self-petition and U-visa eligibility. Culturally tailored interventions have been developed for immigrant and refugee populations. Research has tested interventions specifically designed for immigrant, refugee, and indigenous women experiencing intimate partner violence. These interventions demonstrate that culturally adapted approaches can effectively serve diverse populations. Domestic violence affecting older adults may involve long-standing intimate partner violence continuing into later life, domestic violence beginning later in life, or abuse by adult children or other family members. The intersection of domestic violence and elder abuse creates complex situations requiring attention to both frameworks. Older adults face unique barriers to help seeking, including physical limitations, increased isolation, financial dependence, shame associated with long marriages, lack of services designed for older populations, and difficulty accessing traditional domestic violence shelters that may not accommodate medical needs or disabilities. Healthcare providers should be particularly attentive to signs of abuse in older patients. Florida mandatory reporting requirements for vulnerable adults apply to elderly individuals who meet the definition of vulnerable adult. Healthcare providers must report suspected abuse of vulnerable older adults to the Florida Abuse Hotline. However, competent older adults who are not vulnerable adults retain the right to make their own decisions about reporting and intervention. The National Center on Elder Abuse provides resources and statistics on elder abuse, including situations involving domestic violence. Healthcare providers should be familiar with local resources for older adult victims, which may include adult protective services, elder law attorneys, and domestic violence programs with services tailored to older populations. People with disabilities experience domestic violence at significantly elevated rates compared to people without disabilities. Barriers to help seeking include physical accessibility of shelters and services, communication barriers for individuals with sensory or cognitive disabilities, dependence on abusers for personal care, lack of provider training on disability issues, and social isolation. Abusers may exploit disability-related vulnerabilities in unique ways, including withholding medications, mobility devices, or assistive technology, refusing to provide necessary personal care, threatening institutionalization, or manipulating communication access for individuals who are deaf or hard of hearing. Healthcare providers should be alert to these disability-specific forms of abuse. Healthcare providers should ensure accessibility of screening and services for patients with disabilities. This includes physical accessibility, available interpretation services for deaf patients, plain language communication for individuals with cognitive disabilities, and accommodation of communication support needs. Providers should not assume that caregivers or support persons should be present during private conversations. Domestic violence in rural communities presents distinct challenges, including geographic isolation, limited anonymity in small communities, fewer available services, transportation barriers, and cultural norms that may emphasize privacy and self-reliance. Rural victims may have to travel significant distances to access shelters, courts, or specialized services. Healthcare providers in rural areas may be the primary or only professional contact for domestic violence victims. This increases the importance of screening, providing information and resources, and being prepared to offer telehealth options or connections to services in other communities. Providers should be aware of rural-specific resources and creative solutions for service access. The intersection of rural location with other factors such as agricultural work, gun ownership, and conservative social norms may influence domestic violence dynamics and help seeking in rural communities. Providers should approach rural patients with sensitivity to these contextual factors while still conducting universal screening and offering appropriate resources. Pregnancy represents a period of both elevated vulnerability and increased opportunity for intervention. As discussed earlier in this course, domestic violence during pregnancy is associated with significant adverse outcomes for both mother and child. Prenatal care provides regular private contacts with healthcare providers, creating opportunities for screening and intervention. The American College of Obstetricians and Gynecologists recommends screening for intimate partner violence at least once during each trimester of pregnancy and at the postpartum visit. Screening should occur when the patient is alone, without partners or other family members present. Providers should be prepared to respond to disclosure with safety assessment, danger assessment, safety planning support, and referral to resources. Reproductive coercion, including birth control sabotage and pregnancy coercion, may be present in domestic violence situations. Providers should discuss reproductive autonomy and offer confidential contraception options. Patients who request contraception that can be concealed from partners should have their preferences accommodated when medically appropriate. Postpartum patients remain at risk for domestic violence. The stress of new parenthood, sleep deprivation, and changes in relationship dynamics may exacerbate existing abuse or precipitate new violence. Screening should continue through postpartum visits and pediatric visits for infants. Healthcare providers across maternal and pediatric specialties should coordinate care for families where domestic violence has been identified. Cultural and religious backgrounds influence how individuals understand domestic violence, their willingness to disclose, and their decisions about help seeking. Some cultures emphasize family preservation, privacy about family matters, or specific gender roles that may affect victims' responses. Religious teachings may be interpreted in ways that either support or discourage leaving abusive relationships. Healthcare providers should approach cultural and religious factors with humility, recognizing diversity within communities and avoiding stereotypes. Cultural background does not excuse abuse, but understanding how it influences patient decisions helps providers offer appropriate support. Connecting patients with culturally specific resources and religious leaders who support domestic violence intervention may be helpful. Healthcare providers should be cautious about involving family members or community leaders in domestic violence situations without the patient's explicit consent. Family and community members may have conflicts of interest or may prioritize family preservation over victim safety. Patients should make their own decisions about who to involve in their situation. Language access is essential for effective care of patients with limited English proficiency. Professional medical interpreters, rather than family members or friends, should be used for domestic violence discussions. Telephonic interpretation services can provide access to interpreters in many languages when in-person interpreters are not available. Providers should be aware that interpretation quality varies and should speak in short segments to facilitate accurate interpretation. Religious institutions can be either barriers or bridges to safety for domestic violence victims. Some religious leaders provide supportive responses that prioritize victim safety, while others may encourage victims to remain in abusive relationships or work harder to please their partners. Healthcare providers should not assume that referral to religious counseling is appropriate without understanding the specific religious leader's approach to domestic violence. Patients who wish to incorporate their faith into their response to domestic violence may benefit from referral to religious leaders known to provide supportive, safety-focused counseling. Men experience domestic violence as victims at significant rates, though patterns and presentations may differ from those commonly associated with female victimization. Survey data indicate that approximately 1 in 7 men have experienced severe physical violence by an intimate partner. Male victims face unique barriers including stigma, lack of recognition, limited services, and fear of not being believed. Healthcare providers should screen male patients for domestic violence using appropriate, gender-neutral language. Assumptions that men are perpetrators rather than victims can prevent identification and appropriate response. Male victims may present with injuries, mental health symptoms, or other consequences of abuse similar to female victims. Services for male victims remain limited compared to services for women. Most domestic violence shelters serve women and children exclusively or primarily. However, some programs provide services for male victims, and the National Domestic Violence Hotline can assist male victims in locating appropriate resources. Healthcare providers should be prepared to assist male victims in navigating service systems that may not be immediately accessible. Same-sex relationships involving male partners experience domestic violence at significant rates. Healthcare providers should not assume that domestic violence only occurs in heterosexual relationships, or that it necessarily involves male perpetrators and female victims. Screening should be conducted in all intimate relationships regardless of the genders involved. Module 8, Case Studies and Clinical Application. We have now covered the comprehensive landscape of domestic violence, from foundational concepts through special populations. In this final module, we will apply our learning through 4 detailed case studies that represent the diversity of situations healthcare providers may encounter in practice. Each case study presents a realistic scenario requiring integration of knowledge from throughout this course. Our first case study involves Maria Santos, a 34-year-old Hispanic female who presents to the emergency department at 11:47 p.m. on a Tuesday evening. She is accompanied by her husband Carlos, who remains close to her side throughout triage and attempts to answer questions directed at Maria. Maria's chief complaint is that she fell down the stairs. She reports that approximately 3 hours ago, She tripped while carrying laundry down the basement stairs at home. She states she tumbled down approximately 8 to 10 steps and landed on the concrete basement floor. She initially tried to walk it off but developed increasing pain and swelling to her left arm and decided to seek care. She denies loss of consciousness, headache, neck pain, or other injuries. When asked specifically about how she fell, Maria glances at Carlos before answering and provides vague details about just losing her footing. A chart review reveals that Maria has been seen in this emergency department 3 times in the past 18 months. 8 months ago, she presented with walking into a door, resulting in periorbital ecchymosis, or bruising around the eye. 14 months ago, she presented with rib pain after falling while gardening. 18 months ago, she presented with a wrist sprain after slipping on ice. She has no chronic medical conditions documented. Medications include only occasional ibuprofen for headaches. Maria works part-time as a housekeeper at a local hotel. She and Carlos have been married for 7 years and have 2 children, ages 5 and 3, who are currently with Carlos's mother. Maria reports that she does not drink alcohol or use drugs. When asked about stress at home, she says everything is fine while avoiding eye contact. On physical examination, Maria appears alert and oriented but anxious. She avoids eye contact with the examiner and flinches when staff make sudden movements. Her vital signs show blood pressure of 142/88, heart rate of 96, respiratory rate of 18, and temperature of 98, 4 degrees Fahrenheit. No acute trauma is visible to the head, face, or neck. However, a faint yellowish-green bruise approximately 2 centimeters in size is noted on the right lateral neck, appearing to be 5 to 7 days old. Her left forearm shows significant swelling, tenderness, and deformity at the distal radius and ulna, with limited range of motion due to pain. Her right upper arm has 2 oval-shaped bruises, approximately 3 by 5 centimeters each, on the medial aspect, consistent with grip marks. Her abdomen is soft and non-tender. In addition to the noted bruises, there is a healing linear abrasion approximately 4 centimeters long across the upper back. X-ray of Maria's left forearm reveals displaced fractures of both the distal radius and ulna, a both-bone forearm fracture. At the first clinical decision point, the attending physician needs to ensure private conversation with Maria. Carlos has remained at her bedside throughout the evaluation, frequently answering questions for her and checking his phone. When orthopedic surgery is consulted for the fracture, the attending recognizes this as an opportunity to speak with Maria privately. The attending approaches the situation by stating to both Maria and Carlos, the orthopedic surgeon is going to want to examine Mrs. Santos and discuss surgery options. It's our standard policy to have these consultations one-on-one with patients. Sir, I can show you to our family waiting area where we have coffee, and we'll come get you as soon as the consultation is complete. Carlos appears reluctant but ultimately agrees to leave. At the second clinical decision point, the attending conducts intimate partner violence screening using the HITS tool once alone with Maria. The attending begins by saying, "Maria, I want you to know that everything we discuss is confidential. We ask all of our patients some questions about safety at home because we know that stress and conflict in relationships can affect health. This is a safe space and I'm here to help you, not to judge you." When asked the HITS questions, Maria scores positive, acknowledging that her partner sometimes physically hurts her and frequently screams or curses at her. With gentle, non-judgmental follow-up, Maria begins to cry and discloses that Carlos pushed her down the stairs tonight after accusing her of looking at a male coworker. She reveals that the abuse has been occurring for approximately 5 years and has been getting worse. She discloses that Carlos has choked her a few times when he gets very angry, most recently about 2 weeks ago. She says her children have witnessed some of the violence and that her 5-year-old son has started having nightmares and behavioral problems at preschool. Maria expresses fear about what will happen if Carlos finds out she told anyone. She states, "I can't leave him. He controls all our money and he says he'll take the kids and have me deported if I try to leave. My family is all in Mexico. I have no one here." It is noted that Maria has legal immigration status through her marriage to Carlos, a U.S. citizen. At the third clinical decision point, the attending completes a danger assessment identifying multiple high-risk factors: recent strangulation, escalating violence, controlling behavior, prior injuries, threats regarding children and immigration status, and social isolation. Maria is assessed to be at high risk for severe or lethal violence. The attending provides immediate support and resources. "Maria, I'm very concerned about your safety. What Carlos is doing to you is not okay, and it's not your fault. The choking is especially dangerous. It can cause serious injuries even when it doesn't leave marks. and it tells us that the risk of serious harm is high. I want to help connect you with people who specialize in helping women in situations like yours. They can talk to you about your options, including your immigration rights. There are actually special protections for people in your situation. The attending offers to have a domestic violence advocate come to the emergency department to speak with Maria. Maria agrees to speak with an advocate but states she is not ready to leave Carlos tonight. She is most concerned about her children and asks what will happen to them. At the fourth clinical decision point, the attending must consider mandatory reporting obligations. Maria has disclosed that her children have witnessed violence and that her 5-year-old is showing behavioral effects. Under Florida law, the attending must consider whether a report to the Florida Abuse Hotline is required. The attending consults with the hospital social worker and determines that a report to the Department of Children and Families is warranted, given the children's exposure to violence and documented effects on the older child. The attending explains this to Maria with compassion. Maria, I need to be honest with you about something. Because you've told me that your children have seen the violence and your son is being affected, I'm required by law to make a report to Child Protective Services. I know this might feel scary, but I want you to know that the goal is to help protect you and your children, not to punish you. You're not in trouble. You're trying to protect your kids. The advocate can talk with you more about what to expect and how to work with the system. In the case resolution, Maria meets with the domestic violence advocate, who provides safety planning assistance, information about immigration protections under VAWA, and contact information for the local certified domestic violence center. Maria is not ready to leave tonight, but accepts a safety card with hotline numbers hidden in a makeup compact. She identifies a code word to use with her sister in Mexico if she needs help. The mandatory report to the Department of Children and Families is made with documentation of the domestic violence context. Maria's fracture is surgically repaired and she is discharged with orthopedic follow-up. Documentation carefully records her disclosures, injuries including the strangulation history, and the danger assessment findings using objective language and Maria's own words in quotation marks. Our second case study involves Dorothy Williams, a 78-year-old Caucasian female who presents to her primary care provider for follow-up of hypertension and diabetes management. She is accompanied by her husband of 54 years, Harold, age 82, who drives her to all appointments since she stopped driving 2 years ago due to vision changes from diabetic retinopathy. Dorothy appears well-groomed but thinner than at her previous visit 3 months ago. She is pleasant but seems hesitant in her responses, frequently looking to Harold before answering questions. Harold is attentive but interjects frequently with comments such as, "She doesn't need to worry about that, and I handle all her medications." Dorothy has hypertension, type 2 diabetes, diabetic retinopathy, osteoarthritis, and depression diagnosed 2 years ago following the death of her sister. She takes multiple medications including lisinopril, metformin, glipizide, sertraline, and acetaminophen as needed for arthritis pain. At her last visit, her A1C was 8.2%, which was elevated, and blood pressure was 148/88. Dorothy reports her blood sugars have been running a little high, but states she's not really sure of the exact values because Harold keeps track of all that. She reports poor appetite and has lost 8 pounds since her last visit, now weighing 118 pounds at 5 feet 4 inches. She admits to fatigue and reports she doesn't get out much anymore. When asked about her mood and depression, she glances at Harold and says, "I'm fine. Just tired." On physical examination, Dorothy appears thin and tired, cooperative but guarded. Her weight is down from 126 pounds. Her vital signs show blood pressure of 156/92 and heart rate of 72. Multiple bruises are noted on bilateral upper arms and 1 bruise on the right hip, visible during examination. When asked about the bruises, Dorothy states she is clumsy and bruises easily. Vision is limited per known retinopathy. Cardiovascular and respiratory examinations are within normal limits for age. She has decreased range of motion in knees and hips, consistent with known osteoarthritis. Her affect is flat, she makes poor eye contact and appears anxious when Harold speaks. Laboratory results show her A1C today is 9.1%, increased from 8.2%. Her basic metabolic panel shows BUN and creatinine mildly elevated, suggesting possible dehydration. Her complete blood count shows mild anemia with hemoglobin of 10.8. The physician identifies multiple concerning findings: unexplained weight loss, worsening diabetes control despite patient compliance at previous visits, dehydration, bruising, depressed affect, and a controlling spouse who manages all medications and information. The pattern raises concerns for possible intimate partner violence in an elderly patient, potentially overlapping with neglect. The physician recognizes the need to speak with Dorothy privately, but must navigate this carefully given Harold's controlling presence and Dorothy's dependence on him for transportation and daily care. To create private time, the physician states, Mr. Williams, I need to do a complete physical examination of Dorothy, including a pelvic exam for some of her symptoms. This will take about 20 minutes. You can wait in the waiting room and we'll come get you when we're finished. Harold appears reluctant but agrees. Once Harold leaves, the physician sits at eye level with Dorothy and speaks gently. Dorothy, I'm glad we have a few minutes to talk privately. I've noticed some things that concern me, and I want to ask you some questions because I care about your health and safety. Everything we discuss is confidential unless you tell me someone is hurting you and you're in immediate danger. Using a gentle, open-ended approach, the physician asks about Dorothy's home life. Initially, Dorothy minimizes. Harold is a good husband. He takes care of everything now that I can't see well. With patient, empathetic questioning, Dorothy eventually reveals, he gets frustrated with me. I can't do things like I used to. Sometimes he grabs me too hard when he's helping me up. And if I don't eat what he makes, he gets angry and says I'm ungrateful. Further conversation reveals, Harold controls all finances and does not give Dorothy money. Harold no longer allows Dorothy's friends to visit, saying she needs her rest. Harold often criticizes Dorothy, telling her she's useless and a burden. Harold has on several occasions pushed Dorothy, causing the bruises she attributed to clumsiness. Harold sometimes withholds her diabetes medication as punishment when she misbehaves, which explains the worsening glucose control. Dorothy is afraid to tell anyone because Harold has said he will put her in a nursing home if she complains. Dorothy becomes tearful. I know it sounds bad, but he's all I have. My children live far away. I can't take care of myself. Where would I go? She explicitly states she does not want anyone to contact Harold or report the situation because she fears retaliation. The physician recognizes this as intimate partner violence occurring within the context of an elderly patient with functional dependence. The situation involves physical abuse, including grabbing and pushing, psychological abuse, including criticism and threats of institutionalization, financial abuse through controlling all money, isolation, and neglect through withholding medication. Dorothy meets criteria as a vulnerable adult under Florida law. Under Florida Statute Section 415.1034, healthcare providers must report suspected abuse, neglect, or exploitation of vulnerable adults to the Florida Abuse Hotline. Dorothy, as an elderly person with impaired vision and functional dependence, meets the definition of a vulnerable adult. The physician determines that a mandatory report is required despite Dorothy's expressed wishes. The physician explains this to Dorothy with compassion. Dorothy, I'm so glad you trusted me with this. What Harold is doing to you is abuse, and it's not okay. I have to be honest with you. Florida law requires me to report when I believe a vulnerable adult is being abused. I know this isn't what you wanted, but my goal is to help you be safe. The report doesn't mean you'll be separated from Harold or put in a nursing home. It means someone will come talk with you about your options and make sure you're okay. The physician contacts the hospital social worker, who assists with the report to the Florida Abuse Hotline. The report includes detailed documentation of the physical findings, Dorothy's disclosures in her own words, the medication withholding, and the pattern of control. The social worker also provides Dorothy with information about elder abuse resources and safety planning. In the case resolution, Adult Protective Services conducts an investigation. With support from Adult Protective Services and the local Domestic Violence Center's elder abuse specialist, Dorothy is connected with services including Meals on Wheels, a home health aid funded through Medicaid, and transportation services that reduce her dependence on Harold. Her diabetes medications are refilled at a pharmacy that provides reminder packaging, and the physician's office begins calling Dorothy directly for appointment reminders. Over the following months, with increased support and reduced isolation, Dorothy's health improves and she reports feeling safer at home. Harold is required to participate in a counseling program. The situation is monitored through ongoing contact with Dorothy. Our third case study involves Jalen Thompson, a 6-year-old African-American male who is brought to the pediatric clinic by his mother, Keisha Thompson, age 28, for evaluation of behavioral problems. This is Jalen's first visit to this clinic. The family recently moved from a neighboring county. Keisha reports that Jalen has had behavioral changes over the past 4 to 5 months. He has become aggressive at school, hitting other children and throwing things. He has difficulty following directions and his grades have declined. He has had frequent nightmares, waking 3 to 4 times per week screaming, and has started wetting the bed after being toilet trained for 3 years. He is clingy with his mother and becomes extremely distressed when separated from her. Keisha also notes that Jalen sometimes freezes when he hears loud noises like doors slamming or people yelling. Jalen met all developmental milestones on time. He was previously described as a happy, well-adjusted child who did well in kindergarten. His behavioral changes coincided with a move and change of schools approximately 5 months ago. Jalen lives with his mother and his mother's boyfriend Marcus, who moved in with them approximately 8 months ago. Keisha and Jalen's biological father separated when Jalen was 2 years old. The father has minimal contact. Keisha reports she works as a nursing assistant and Marcus is between jobs. When asked about stress at home, Keisha initially states everything is fine but appears tense. When asked specifically about how Jalen gets along with Marcus, Keisha hesitates. He's adjusting. Marcus has high expectations. The physician notes that Keisha has a faint bruise visible on her left forearm, partially covered by her sleeve. On physical examination of Jalen, he appears well-developed and well-nourished, cooperative but subdued. He makes poor eye contact with the physician. His vital signs are age-appropriate. His height and weight are at the 50th percentile, consistent with previous records. No bruising, abrasions, or other signs of trauma are visible on his skin. Full physical examination is otherwise unremarkable. Developmental screening is age-appropriate with some regression in emotional regulation and behavior consistent with the reported symptoms. The pediatrician identifies several concerning patterns. Jalen's behavioral changes including aggression, nightmares, regression, hypervigilance to loud noises, and clinginess are consistent with trauma exposure. The timeline correlates with Marcus moving into the home. The mother appears stressed and has a visible bruise. Jalen's symptoms are classic for children exposed to domestic violence. The pediatrician recognizes the need to assess for both direct child abuse and exposure to domestic violence. The approach must be careful, as directly questioning Keisha in front of Jalen could put Jalen in an uncomfortable position and potentially reveal information that could endanger Keisha if Marcus learned of the disclosure. The pediatrician speaks with Jalen first, using age-appropriate language. Jalen, I'm going to ask you some questions to get to know you better. Sometimes kids have worries or things that bother them, and it's my job to help. Is there anything that makes you feel scared at home? Jalen looks at his mother and says quietly, when they yell. I don't like the yelling. When asked who yells, he says Marcus. He yells at Mommy. Sometimes Mommy cries. When asked if Marcus has ever hurt him, Jalen shakes his head but adds, he threw my toys once when I was bad. The pediatrician then arranges for the medical assistant to engage Jalen with an activity in the exam room while speaking with Keisha privately in an adjacent room. In the private conversation with the mother, the pediatrician begins, Keisha, Jalen shared some things with me that I want to discuss with you. He mentioned that there's yelling at home between you and Marcus and that it scares him. I also noticed a bruise on your arm. I want to ask you directly, is Marcus hurting you? Keisha initially denies it's nothing. We argue sometimes. Every couple does. The pediatrician responds with empathy, I understand. I want you to know that I ask all families about safety at home because it affects children's health. Jalen's nightmares, bedwetting, and aggression are classic signs of a child who is being affected by stress and conflict at home. Kids are very sensitive to what happens around them, even when they don't witness it directly. Keisha becomes tearful. I didn't know it was affecting him this much. I try to protect him. I send him to his room when Marcus gets angry. But he hears everything in that apartment. She then reveals that Marcus has been physically violent with her on multiple occasions over the past 6 months, including pushing, slapping, and on one occasion choking her. The abuse has escalated since Marcus lost his job. Keisha states that Marcus has never directly hit Jalen, but has grabbed him roughly twice and thrown his toys as Jalen described. The pediatrician must now consider mandatory reporting obligations under Florida Statute Section 39.201. The situation involves a child, Jalen, who has been grabbed roughly by Marcus, which may constitute physical abuse, a child exhibiting significant psychological effects from exposure to domestic violence, and a mother, Keisha, who is being abused by Marcus, including strangulation. The pediatrician determines that a report to the Florida Abuse Hotline is required based on the physical contact with Jalen and the significant harm from domestic violence exposure. However, the report will be made in a way that frames Keisha as a protective parent who is also a victim, not as a neglectful parent. The pediatrician explains to Keisha, Keisha, I'm legally required to make a report about Jalen's situation. I know that might feel scary, but I want you to understand something important. This report will document that you are a protective mother who is also being abused. You are not in trouble. The goal is to get both you and Jalen the support you need to be safe. I'm going to recommend that you and Jalen be connected with the local domestic violence center, which can help with safety planning and support services. Keisha is frightened about Marcus finding out. If he knows I told someone, he'll kill me. That's not an exaggeration. He said it. The pediatrician takes this threat seriously as a lethality indicator and works with the clinic's social worker to immediately connect Keisha with a domestic violence advocate by phone while still in the clinic. The domestic violence advocate assists with immediate safety planning. Keisha identifies that her mother's house would be a safe place to go. The advocate helps Keisha develop a plan to leave with Jalen that evening while Marcus is at a friend's house. The pediatrician provides documentation of Jalen's symptoms and their connection to domestic violence exposure, which may be useful for legal proceedings, including protective orders and custody matters. The mandatory report is made to the Florida Abuse Hotline with clear documentation that the mother is a domestic violence victim who is protective of her child. The child's symptoms result from exposure to domestic violence perpetrated by the mother's boyfriend against the mother. The physical contact with the child, grabbing roughly and throwing toys, was perpetrated by the boyfriend, not the mother, and the mother is actively working with domestic violence services to establish safety. In the case resolution, Keisha and Jalen go to her mother's house that evening. With assistance from the Domestic Violence Center, Keisha obtains an injunction for protection. The Child Protective Services investigation substantiates concern for Jalen but correctly identifies Marcus as the perpetrator and Keisha as a protective parent. The case is referred to services rather than resulting in any action against Keisha. Jalen begins play therapy to address his trauma symptoms. Over the following months, his nightmares decrease, bedwetting resolves, and his behavior at school improves significantly. Keisha and Jalen eventually move into their own apartment with assistance from the Domestic Violence Center's transitional housing program. Our fourth and final case study involves Rebecca Morrison, a 42-year-old Caucasian female presenting to urgent care for evaluation of a sinus infection. She is a marketing executive for a large corporation and has been a patient at this practice for 5 years with an unremarkable medical history. Rebecca reports nasal congestion, facial pressure, and purulent nasal discharge for the past 5 days. She is requesting antibiotics so she can get through an important presentation next week. She appears well-dressed and composed but seems tired and distracted. During the interview, she winces when turning her head. On physical examination, her vital signs are within normal limits. She has mild maxillary sinus tenderness bilaterally with clear nasal discharge and pharynx without erythema. No acute sinusitis findings are present on examination. Her symptoms appear to be viral upper respiratory infection. However, when examining her neck, the provider notes tenderness and observes that Rebecca has covered a mark on her neck with concealer that has partially rubbed off, revealing a linear bruise. The provider also notes bruising on Rebecca's left shoulder blade when she lifts her shirt for lung auscultation. The provider states, "Rebecca, I noticed some bruising on your neck and back. Can you tell me what happened?" Rebecca pauses, then says flatly, "My husband and I had an argument. It got physical. It's not the first time." She then adds, "I don't want to talk about it. I just need antibiotics for my sinuses." The provider responds gently, "Thank you for telling me. I can see you don't want to discuss this, but I'm concerned about your safety. Arguments shouldn't result in injuries." "What you're describing is domestic violence." Rebecca interrupts, "I know what it is. I'm handling it. I don't need resources, I don't need a hotline, and I don't need a social worker. I'm not leaving him. We've been married for 18 years. He's the father of my children. This is my business and I'll deal with it in my own way. Can we please just focus on why I came here?" The provider acknowledges Rebecca's stated preferences while fulfilling clinical responsibilities. "I hear that you're not looking for resources right now, and I respect your right to make your own decisions. But I do need to ask a few questions because some situations are more dangerous than others, and I want to make sure you're not in immediate danger." With Rebecca's reluctant agreement, the provider conducts a brief safety assessment. "Has the violence been getting worse or more frequent?" Rebecca nods. "It's been more often lately. The past year." "Has your husband ever choked you or put his hands around your throat?" Rebecca's hand goes to her neck, touching the bruise. "Yes. That's what this is from." "Does your husband have access to guns?" Rebecca, "He has several. He's a hunter." "Has he ever threatened to kill you?" Rebecca hesitates. "He says things when he's angry. I don't take them literally. The provider recognizes multiple lethality risk factors: escalating violence, recent strangulation as evidenced by the neck bruise, access to firearms, and possible threats. Yet Rebecca is clearly not ready to engage with services. The provider responds, "Rebecca, I have to be honest with you. Some of what you've told me, the choking, the guns, the violence getting worse, these are factors that research tells us increase the risk of serious harm. I'm worried about you. I understand you're not ready to take action right now, and I'm not going to pressure you. But I want you to know that help is available whenever you're ready, whether that's tomorrow or a year from now." The provider continues, "What I would like to do is give you some information to keep, just in case. A card with a hotline number that you can hide. And I'd like you to know that if anything changes or you ever want to talk, you can call this office and ask for me, and we'll find a way to talk privately." Rebecca accepts the card, placing it in her wallet. "I appreciate your concern. I really do. I'm just not ready for all of that. My kids are teenagers. They'll be in college in a few years. Then I'll figure out my next steps. For now, I need to hold things together." The provider documents the visit carefully. The physical findings, including the bruising patterns and evidence of strangulation using objective, descriptive language, Rebecca's disclosure of ongoing domestic violence using her words in quotation marks, the risk factors identified, resources offered, and Rebecca's decision to decline services at this time. The provider notes the plan to provide ongoing support and reassessment. Regarding the original complaint, the provider explains that Rebecca's symptoms are consistent with a viral upper respiratory infection that does not require antibiotics, provides symptomatic treatment recommendations, and tells Rebecca to return if symptoms worsen. The provider schedules a follow-up appointment in 2 weeks, framed as checking on how your cold is doing. This provides an opportunity for ongoing contact and reassessment without raising suspicion if Rebecca's husband sees the appointment. Rebecca keeps the follow-up appointment. Her upper respiratory infection has resolved, and she has no new injuries. She does not bring up the domestic violence, and the provider does not push, but does ask, "How are things at home?" Rebecca says the same. "He was remorseful after last time. Things have been calm." The provider recognizes the honeymoon phase of the cycle of violence. Over the following months, Rebecca presents twice more for medical complaints. At each visit, the provider briefly checks in about safety and reminds her that support is available. At one visit, Rebecca mentions that she found a therapist and has started individual counseling to work on some personal issues. The provider recognizes this as a positive step, even though Rebecca doesn't frame it as related to domestic violence. 18 months later, Rebecca calls the office and asks to speak with the provider. Her voice is shaking. "I'm ready. I need help." Her youngest child has left for college, and a recent violent episode left her with a black eye that she cannot hide at work. She finally used the hotline number she had kept. She is connected with an advocate and begins the process of leaving. The provider's consistent, non-judgmental support over time, providing information without pressure, maintaining the relationship, and being available when Rebecca was ready, ultimately contributed to Rebecca's ability to seek help on her own timeline. Course summary and conclusion. This comprehensive course has provided you with the knowledge necessary to identify, respond to, and assist victims of domestic violence. Let us summarize the key takeaways from each module. Domestic violence is a pervasive public health problem affecting millions of Americans and hundreds of thousands of Floridians annually. Healthcare settings represent critical venues for identification and intervention, as victims often present to healthcare providers multiple times before their abuse is recognized. The health consequences of domestic violence extend far beyond acute injuries to include chronic conditions, mental health disorders, reproductive health complications, and neurological effects from traumatic brain injury and strangulation. Understanding the dynamics of domestic violence, including the cycle of violence and power and control tactics, helps healthcare providers respond with empathy and appropriate support. Recognizing the multiple barriers to leaving helps providers maintain realistic expectations and provide ongoing support regardless of victims' immediate decisions. Leaving an abusive relationship is a process, not an event, and victims may require multiple supportive contacts before taking action towards safety. Universal screening using validated tools, implemented within a trauma-informed care framework, maximizes identification of domestic violence in healthcare settings. Creating a safe environment for disclosure and responding with empathy to disclosures are essential skills for all healthcare providers. Brief screening tools such as HITS, the Abuse Assessment Screen, and the Partner Violence Screen can be integrated into routine clinical workflows to ensure consistent screening of all patients. Florida law establishes specific requirements for documentation and reporting that healthcare providers must understand and follow. Mandatory reporting applies to suspected child abuse and vulnerable adult abuse, while competent adult victims generally retain the right to make their own decisions about reporting. Documentation should be thorough, objective, and follow best practices for potential legal use while maintaining patient safety as the primary concern. Florida's 42 certified domestic violence centers provide comprehensive services to victims and their families, including emergency shelter, counseling, case management, and legal advocacy. Healthcare providers should be familiar with local resources and prepared to make warm referrals while respecting patient autonomy regarding service utilization. The Florida Domestic Violence Hotline at 1-800-500-1119 and the National Domestic Violence Hotline at 1-800-799-7233 provide 24/7 access to crisis support and referrals. Special populations including LGBTQ+ individuals, immigrants, older adults, individuals with disabilities, rural populations, pregnant patients, and male victims may face unique barriers and considerations requiring culturally responsive approaches to care. Healthcare providers must be prepared to address the specific needs of diverse patient populations while recognizing that domestic violence affects individuals across all demographic groups. Danger assessment and safety planning are critical components of domestic violence response. Healthcare providers should be alert to risk factors for severe violence and lethality, including prior strangulation, access to firearms, threats to kill, escalating violence, and separation. Safety planning helps victims increase their safety whether or not they choose to leave the relationship immediately. The knowledge and skills addressed in this course represent the minimum competencies required for effective domestic violence response. Healthcare providers are encouraged to pursue additional training, remain current with evolving best practices, and work with their institutions to ensure comprehensive policies and protocols are in place. Every healthcare encounter represents an opportunity to identify domestic violence, provide support, and potentially save lives. The commitment of Florida healthcare professionals to addressing domestic violence makes a meaningful difference for patients, families, and communities across the state. Thank you for your attention throughout this course. Your dedication to continuing education on this critical topic reflects your commitment to providing the highest quality care to all patients, including those who may be experiencing domestic violence. By applying the knowledge gained through this course, you can fulfill your professional and ethical obligations while making a profound difference in the lives of domestic violence survivors and their families. We will now review the exam questions to solidify your understanding of the key concepts covered in this domestic violence continuing education course for Florida healthcare professionals. Question 1. According to CDC National Intimate Partner and Sexual Violence Survey data presented in this course, approximately what percentage of women experience contact sexual violence, physical violence, or stalking by an intimate partner during their lifetime? The correct answer is 41%. Rationale: the Centers for Disease Control and Prevention's National Intimate Partner and Sexual Violence Survey represents one of the most comprehensive ongoing surveillance efforts tracking intimate partner violence in the United States. The 41% figure reflects the staggering prevalence of this issue among women, encompassing multiple forms of abuse including contact, sexual violence, physical violence, and stalking. This statistic is essential for healthcare providers to understand because it means that nearly half of all female patients you encounter may have experienced some form of intimate partner violence during their lives. Note that the corresponding figure for men is 26%, which, while lower, still represents a significant public health concern. Question 2. According to the cycle of violence model described by Lenore Walker, which phase is characterized by the abuser's expressions of remorse, apologies, and promises to change? The correct answer is the honeymoon or reconciliation phase. Rationale: Lenore Walker's cycle of violence model, first introduced in 1979, describes a predictable pattern that often occurs in abusive relationships. The cycle consists of 3 primary phases. The tension-building phase involves gradual escalation of stress, minor conflicts, and increasing anxiety. The acute battering incident is the actual episode of physical, sexual, or severe emotional abuse. The honeymoon or reconciliation phase follows the acute incident and is characterized by the abuser expressing remorse, apologizing profusely, making promises to change, and often displaying loving and affectionate behavior. Understanding this phase is clinically important because it helps explain why victims often return to their abusers. During this phase, victims may genuinely believe the abuse will stop, making it a particularly vulnerable time for intervention. Question 3. The HIT screening tool is a validated 4-item instrument used in healthcare settings. What does the acronym HIT stand for? The correct answer is hurt, insult, threaten, scream. Rationale: the HIT screening tool was developed specifically for use in busy healthcare settings where time constraints often limit the ability to conduct lengthy assessments. Each letter represents a question about whether a partner has hurt, insulted, threatened, or screamed at the patient. The tool uses a 5-point frequency scale ranging from never to frequently for each item, with total scores ranging from 4 to 20. A score of 10 or higher generally indicates a positive screen for intimate partner violence. The HITS tool has been validated across multiple populations and settings, demonstrating good sensitivity and specificity. Its brevity and ease of administration make it particularly useful in primary care, emergency department, and other clinical settings where universal screening is recommended. Question 4. When documenting domestic violence cases in medical records, which of the following represents best practice according to National Institute of Justice guidance? The correct answer is use the patient's own words in quotation marks. Rationale: proper documentation in domestic violence cases serves multiple critical functions, including supporting patient care, providing potential legal evidence, and establishing a medical record that may be used in future proceedings. The National Institute of Justice emphasizes that healthcare providers should document exactly what the patient reports, using their own words placed in quotation marks preceded by phrases such as patient states or patient reports. This approach maintains objectivity and preserves the evidentiary value of the record. Healthcare providers should avoid stating conclusions about who caused injuries, commenting on victim credibility or sobriety, or using language such as alleged abuse, all of which could undermine the victim's credibility if the record is used in legal proceedings. Detailed, objective documentation using the patient's own words creates the most accurate and legally useful medical record. Question 5. Under Florida law, which of the following situations triggers a mandatory reporting requirement for healthcare providers? The correct answer is suspected child abuse or neglect. Rationale: Florida statutes, Section 39.201 establishes clear, mandatory reporting requirements when healthcare providers suspect child abuse, abandonment, or neglect. This mandatory reporting requirement applies regardless of whether the child is a direct victim of domestic violence or is exposed to violence in the home. It is crucial to understand that competent adult victims of domestic violence generally retain the right to make their own decisions about reporting. Healthcare providers should not report domestic violence involving competent adults to law enforcement without the victim's consent, as doing so can actually increase danger to the victim by removing their autonomy and potentially triggering retaliation. However, when children are involved, either as direct victims or as witnesses to domestic violence, the mandatory reporting requirement is triggered, and providers must report to the Florida Abuse Hotline. Question 6. How many certified domestic violence centers does Florida have that provide comprehensive services, including emergency shelter, counseling, case management, and legal advocacy to victims and their families? The correct answer is 42. Rationale: Florida has established a statewide network of 42 certified domestic violence centers, all certified by the Florida Department of Children and Families. These centers provide a comprehensive array of services to victims and their families, including 24-hour emergency shelter, crisis intervention, safety planning, individual and group counseling, case management services, legal advocacy, and children's programs. As a healthcare provider, knowing that these 42 certified centers exist throughout Florida enables you to provide meaningful referrals to patients who disclose abuse. Each center operates a local hotline in addition to the statewide Florida Domestic Violence Hotline. Familiarity with the Certified Domestic Violence Center serving your geographic area allows you to provide patients with specific, actionable resources during safety planning discussions. Question 7. According to research cited in the course, transgender individuals are approximately how many times more likely to experience physical, intimate partner violence compared to cisgender individuals? The correct answer is 2.2 times. Rationale: meta-analytic research examining intimate partner violence among transgender populations has demonstrated significantly elevated rates compared to cisgender individuals. Specifically, transgender individuals are approximately 2.2 times more likely to experience physical intimate partner violence, This disparity reflects the intersection of multiple vulnerability factors, including social marginalization, discrimination, economic instability, and barriers to accessing supportive services. Healthcare providers must recognize that transgender patients may face unique challenges when experiencing intimate partner violence, including fear of being outed, concerns about encountering discrimination when seeking help, and limited access to affirming shelter services. Understanding these elevated risk rates should inform trauma-informed screening practices and ensure that all patients, regardless of gender identity, receive appropriate assessment and support for intimate partner violence. Question 8. Research cited in the course indicates that prior non-fatal strangulation by an intimate partner increases the risk of subsequent homicide by approximately what factor? The correct answer is B, 7 times. Rationale? Prior non-fatal strangulation is one of the most significant predictors of future lethal violence in intimate partner relationships. Research demonstrates that victims who have been strangled by an intimate partner face a 7-fold increased risk of subsequent homicide. This makes strangulation history a critical indicator for danger assessment and safety planning. Healthcare providers should routinely assess for strangulation history when screening for intimate partner violence, as victims may not spontaneously disclose this information. Signs and symptoms of strangulation may be subtle or absent, yet the act itself represents a profound demonstration of the abuser's power and control and willingness to use lethal force. When strangulation history is identified, providers should recognize the extreme danger and prioritize immediate safety planning and connection to domestic violence advocacy services. Question 9. According to the course, which of the following is an important consideration when developing a safety plan for a domestic violence victim in the digital age? The correct answer is B, checking phones and devices for tracking apps or spyware. Rationale: technology safety has become an increasingly critical component of comprehensive safety planning for domestic violence victims. Abusers frequently use technology to monitor, track, stalk, and control their victims. The course identifies several specific technology safety considerations that should be addressed during safety planning. These include checking phones and devices for tracking applications or spyware that the abuser may have installed, creating new email accounts that are not known to the abuser, changing passwords on all accounts, and being cautious about location sharing features on devices and social media platforms. It is important to note that safety planning should respect victim autonomy rather than impose requirements such as immediately deleting social media accounts or changing phone numbers. The focus should be on empowering victims to identify and address technological monitoring in ways that enhance their safety without increasing risk through confrontation with the abuser. Question 10. Which of the following is a key principle of trauma-informed care as applied to intimate partner violence screening? The correct answer is D, empowerment, voice, and choice for the patient. Rationale: trauma-informed care represents a fundamental shift in how healthcare providers approach patients who have experienced trauma, including intimate partner violence. The key principles of trauma-informed care include safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and sensitivity to cultural, historical, and gender issues. When applied specifically to intimate partner violence screening, these principles guide providers to create safe and private environments for disclosure, be transparent about confidentiality and its limits, including mandatory reporting requirements, involve patients in decision-making about their care, and respect patient autonomy throughout the process. Trauma-informed care does not require victims to provide detailed accounts of all abuse incidents, does not prioritize evidence collection over patient comfort, and centers on the patient's experience rather than focusing primarily on perpetrator behavior patterns. By embracing empowerment, voice, and choice, providers create conditions where patients feel safe to disclose and collaborate in developing safety strategies. This concludes the exam review for the Domestic Violence Continuing Education course for Florida healthcare professionals. The concepts covered in these 10 questions represent essential knowledge for meeting your professional obligations under Florida law and providing competent, compassionate care to patients affected by domestic violence.